We'll move to the next one. We're moving into imaging, neuroradiology. So it's going to be lesion detection in neuroimaging using machine learning. Risto Grkovski from the Neuroradiology Department of the University Hospital. Welcome.
Yes, hello. Can you see my PowerPoint just to double check?
Yes, we can.
Okay. Hello, everybody. Thank you for having me here. My name is Risto Grkovski. I'm a radiology resident from Maribor's observership at Neuroradiology Department in Zurich, and I'll be presenting this talk titled Lesion Detection Neuroimaging Regard to Machine. So I have no conflict of interest. So as a short introduction, basically when it comes to most important topic in machine learning in image detection in neuroimaging is first the endeavor itself to detect lesions, it normal from abnormal, and to single out what is and define what is normal and abnormal within organs or a specific patient. For example, if you look at the journal of cortical atrophy, we would assess it differently when it comes to elderly patient under in comparison to younger patient, where it could actually mean something relevant. And then, of course, lesion detection is the basic step, and then from then on, we can make further steps such as lesion segmentation, disease assessment, prognostication, and prediction of treatment response. So just to sum up, the a lot has already been said in regard to machine learning and neural networks at this symposium today. Presenting a very typical architecture of convolutional neural network, which is most commonly used network in lesion detection, have certain layers of certain convolutional layers which take specific features of a forward to the end. Hello. So this basically called forward propagation on the result that we want to have. For example, when we are training the network to have a certain result, then we would also need a justification of weights in each layer. So this would be then the back propagation. So we have forward and back method of learning convolutional neural networks. Okay, so what are we doing currently at USZ? There was a study recently done by colleagues and by Dr. Winkelhofer, so in this study, around 240 patients were included. Around 700 images were taken, digital subtraction images, which we see in this picture. These are images, so these, for those who are not familiar with radiology, these are images by when interventional neuroradiologist injects a contrast inside the vessel, and then we take the so endovascular, the contrast endovascularly, we take the image with the X-ray, and basically what we are looking for is abnormal bulging of vessel walls, such as we see here. It's called aneurysm. So basically, the 700 imaging data sets were divided roughly half those with aneurysm and those without. Those images, as it is normal with every training the network protocol, were divided into validation and training to produce optimal results, and the results indeed were very impressive. The network 87 correctly detected aneurysms and 79% correctly localized aneurysms. But this is not all. Currently, this is so, it's not just neuroradiology. There's it's not only at the clinical department. We also research team who is doing machine learning and lesion detection segmentation. Also have a physicist team who is also doing research in machine learning, and we are as well collaborating with the Department of Neurosurgery, Radiology, Neurology, and as well as other institutions such as ETH. So, and what are the clinical applications? So, in clinical application, first, what we have is as a protocol. It's not a protocol, but it's basically a system Siemens called patient pathway from scan to image report. And basically what it does, it guides us through every step. So the moment patient comes to us for a CT scan, we have an AI supported software, so mechanism, which helps us to accurately reproduce patient positioning, to help us planning, to use then to detect metal detector, to help in image acquisition, contrast dosing in order if some further imaging is necessary, all with the end goal to provide the optimal results. So when we have from the start, when the patient comes to the CT, all the way this pathway to the end, till we have appropriate imaging that we want, that we have all information so that the clinician can make an appropriate decision. And then another clinical application that we use is called RAPID. Perhaps somebody has already heard about it. This is widely available software which provides automatically delivered, quantified, color-coded, both perfusion and diffusion weighted. So perfusion and diffusion weighted maps are basically imaging modalities that provide us to see and to quantify the ischemic tissue after ischemic stroke, which is still viable, so-called penumbra. And that is very important to give information to give quick and accurate information to the intervention of the radiologist and neurologists and all the clinicians who are physicians and interdisciplinary stroke team, which is present in assessing those patients in order to provide the and basically at the same time as this, as the imaging is done, this provides the segmentation, the area, as we see here with red, the area that shows the viable tissue. And as again, we have the diffusion weighted imaging as well as perfusion images, and we can use that, we can utilize that both on MRI images as well as CT images. So we have already, I already talked about machine learning aided software in stroke imaging. So basically, if we look at clinical applications, can be divided into three categories. First, like I said, in stroke imaging, when it is not a problem to detect a lesion, but it is very welcome that we have a system that would provide us a very quick and reliable assessment options in patient in order to maybe enhance the process of treatment. Then in the second category, we have so-called incidental findings, also relevant incidental findings. Here, for example, we already talked about the study about brain aneurysm so it is important to detect relevant brain aneurysm as well as this could be also applied in multiple sclerosis. It's difficult to assess if the changes, if there is any changes in location or in time, as some changes not recognize the difference between the previous images. And then the third and final category, which is now of machine learning in neuroimaging, neuroradiology, is to detect images, changes that are not seen by the human eye. So these are changes that are below the threshold of a human's reader directly detected. So basically, we as neuroradiologists we don't assess it, but still there are now technique can assess this. For example, here we have an interesting study that we recently published, which shows that basically machine learning algorithm was utilized detecting changes in schizophrenia, where, for example, we as a neuroradiologist, we have no way to say and to quantify the criteria changes, for example, like we have in multiple sclerosis or other pathologies. So, in conclusion, we already mentioned a few promising, so there are already some promising research ideas going on at our department, other department, as well as clinical applications, and more are being developed. But at this point, one should have to think about one step further. So nowadays, everybody is doing machine learning. We have a lot of algorithms and everything, but perhaps it is time to take it to the next level. So to start think how we would deliver to the patients in everyday practice. And for this, we would need a reliable, transparent, secure, efficient system in order to deliver this locally or globally. And this would not just require the collaboration of physicians, but physicians, researchers, academics, as well as private capitalists, startups, so everybody to kind of like group up and to provide this as this kind of next step in providing artificial intelligence in imaging. But amongst all this, one should not also forget the human factors such as emotional intelligence and communication skills, which by AI. Thank you for having me.
Thank you. Very important topic and definitely a very promising topic. Any questions on the chat already? Okay, I think we have still time for one question. Well, I will have one question then. It's surprising that the size was not different between the detected and not detected aneurysms, which is a little bit worrisome from the clinical standpoint of view. You know, all the studies usually show that when you compare machines or different techniques, the size matters. So do you have any explanation why the size of the detected and undetected aneurysms was not different, was not influenced by being detected or not detected?
So at this point, I would have to take a closer look of the study, because this was done before I was here. As I understand, basically that would perhaps, but this is just my guess, would be that perhaps it should be like if perhaps the ones that were detected were bigger, and that would be kind of like one explanation why it was detected. Whereas when it comes to the no difference in size, means that there was no bias in this in the group which was detected and not detected. So that would be my guess, but I can double check also with Dr. Winkelhofer, and I can provide the correct answer by email or any other matter.
Well, earlier on, Winkelhofer was actually logged in. I don't know if he wants to make a comment, if he's still here.
He's still there. He's there.
We'll give him 10 seconds to switch on his microphone, or to, otherwise we'll just move on. Okay, well, thank you. We'll move on.
Thank you.
Thank you.